Good afternoon, everyone. It is 12:02 or 12:03 p.m. Thank you so much for joining us for the October Bio Coffee Chat. For those of you who don't know me, I'm Karen Holzer. I'm the Senior Director of Patient Advocacy and Alliance Development here at Bio. And we have a wonderful panel of experts here today talking about open enrollment, the IPA 2028 guidance, which is setting the stage for the next round of drug price negotiations under the Inflation Reduction Act, and how all of these things fit together. So I know this will be a jam-packed, really hopefully informative time. But before we get started, I would be remiss if I didn't remind everyone of the fact that next week we will have our patient summit in Washington, D.C. I put the link in the chat. Registration is free for patient groups for our bio members. We hope to see many, if not all of you, in DC. There'll be lots of conversations along the lines of what we talk about today, as well as others. So I think we have a jam-packed agenda, and just wanted to remind everyone that that event is coming up very, very quickly here now. With that, it is my great privilege to introduce our panelists. And in the chat, you will see their impressive bios. I will ask each of you to briefly introduce yourself and your organizations. You'll do a much better job at that than I ever could. But really quickly, we have Bonnie Duffy here from MapRx. We have Tiffany Westbridge Robertson from AI Arthritis and Kimberly Beer from the National Health Council. And one of the things that all three organizations really have in common is the incredible amount of tools, resources, and data that they provide that everybody in the patient community can use. And so I'm just really excited that we are here today to talk about a lot of really timely issues. Bonnie, may I start with you? Would you mind briefly introducing yourself and MapRx and give us a little bit of flavor of what MapRx is and why it was started?
Great. Thank you so much, Karen. My name is Bonnie Duffy. I serve as the convener of the MapRx Coalition. Our coalition is a group of over 60 national patient advocacy and beneficiary organizations, and we're gathered together around Medicare Part D. The coalition was started around the time of implementation of the plan. You might remember prior to 2003, Medicare didn't cover prescription drugs, and Congress passed legislation enacting Medicare Part D, which was implemented for the first time in 2006. A lot of patient advocacy organizations and organizations representing older adults and Medicare beneficiaries at the time were very concerned about two things, really, that people would know about this benefit and be able to sign up, and also that groups like ours were engaging with Congress and the administration, specifically CMS, to make sure that as the program was rolled out, it would work for beneficiaries and ultimately provide good quality access to prescription drugs in the Medicare program. So we've come a long way since 2006, and yet we still are very much focused Medicare Part D, making sure beneficiaries understand what their options are and why to shop, and then also educating stakeholders and engaging in advocacy here in DC, both with Congress and the administration around Part D. I'm happy to say that my two co-speakers are, their organizations are members of MapRx, and I also see some other MapRx members around the table. So thank you very much, Karen, for having us here today.
Wonderful. Thank you so much. And maybe we can share everybody's contact information in the chat or afterwards in case anybody wants to follow up or anybody's interested in joining either of your organizations. So, Bonnie, it's open enrollment time. And I know it's the second year of what is lovingly called the M3P, the Medicare Prescription Payment Plan program, which, and you'll explain that much better than I can, but in a nutshell, it allows seniors to spread out, some seniors to spread out drug costs over the plan year. Um, can you talk a little bit about what that program is, why it matters to um, patients, and kind of how things have been going the
Yeah.
first
So,
year?
thank you, Karen. And it is open enrollment for Medicare Part D right now. It goes October 15th through December 7th. And I will put in the chat a link to our website. And I'm sure we'll talk throughout this session about open enrollment and what beneficiaries face. But one of the changes that Congress made when they passed the IRA was establishing this new program that Karen mentioned. It is called the Medicare Prescription Payment Plan. And my understanding is the staff at CMS who are implementing and working on this plan like to call it by its full name. In this program, will call it M3P because that seems to roll off the tongue a little bit better than the mouthful. Um, the M3P is a plan that the idea behind it is, I will say, at MapRx, one of the things that we do is exchange information around the table. What are you hearing from the constituents that you serve? And one of the things that we were hearing, particularly from the cancer group, was astounding data of the number of beneficiaries who would walk away from the pharmacy counter without filling a cancer drug because of a high out-of-pocket cost. And started looking into it and came up with the idea to give Medicare beneficiaries the option to smooth out their out-of-pocket costs over the course of the year. So think of it as if you go in January and you have a high co-payment that month, instead of having to put all of your budget in the first of the year or in your first fill, you have the opportunity through this program to spread the cost through the year. We also at MapRx believe that this program will benefit people who also take multiple prescriptions and have multiple copays that they might be paying. We could give an example of the extremes of someone with cancer who has a high first fill, or perhaps somebody with lupus who might be taking 7 or 8 different prescription medications and have high out-of-pocket costs. So this concept is very simple in that I think all of us do our budgeting for the year, and the idea of spreading things out rather than having to pay one lump sum is attractive. In the details, as CMS implemented it, as Congress envisioned it, or put it into statute, it was much more complicated than any of us envisioned, and it really became a fairly large math problem of helping beneficiaries understand the impact of their costs across the course of the year. So the decisions that beneficiaries and potentially their helpers, caregivers, or the senior health insurance counseling program advocates are having to do is a little bit more of a complex decision-making process. However, in this first year of the program, we have found through a couple organizations that have done surveys that people who have signed up for the program are generally pleased with it and understand the program and would like to continue in it. The problem in this first year has been that a lot of beneficiaries who might benefit from it have not either heard about it or signed up for it. And so we believe that in a first year, maybe even in the first year of any new public benefit, especially for Medicare beneficiaries, that there may be a slow uptick. There also have been a lot of other changes. And so to reach beneficiaries, it may have been a challenging time. But MapRx, after we've talked to our member organizations, we have surveyed SHIP counselors and spent a fair amount of time looking at data from companies that and organizations that did analyze it. We believe much more could be done both on educating beneficiaries and making the enrollment process easier. One change that CMS has made this year is that if beneficiaries have already signed up for the program, they can automatically stay in. They don't have to re-enroll. One of the things that we're looking at or that we've examined is the beneficiaries can learn about the benefit on Plan Finder, but they have to go directly to their plan to enroll in this. And we know from some surveys that it takes a lot of phone calls, time on the phone, and jumping through hoops to sign up for this plan. So we'd like to see it be made easier. And we'd also like to see CMS make more requirements of plans and also of CMS itself in terms of educating beneficiaries versus really just leaving it up to plans or organizations like MapRx and yours to educate beneficiaries about M3P.
Wonderful. And I know you all have a wonderful, I think, MP3 guide, it's called, on the website to really help people navigate. Can you talk a little bit more about what kinds of education and outreach you're doing in particular right now, leading up to the beginning of the next plan year on
So
MP3?
every year, MapRx does an open enrollment guide, and I will put a link to our website and to the guide in our chat so you can go to it. And the guide is targeted both to stakeholder organizations, to people like all of us gathered around this table, but also program staff from your organizations and local organizations who might be have helpers or caregivers who are helping people make these decisions. One of the things that MapRx does is we through this open enrollment guide, we try through our organizations, through outreach to the Hill and to caseworkers and people who work in the district offices of members of Congress, also through the SHIPs or the Senior Health and Insurance Counseling programs. We try to spread our open enrollment document far and wide so as many people as possible could benefit from it. Another thing that we do for our member organizations is if they're interested, give them the art files for the open enrollment guide, and they can put their own logos on the guide and also add information. It might be, again, to use lupus for an example, one thing that the Lupus Foundation of America does each year is add a couple pages to our guide about lupus, some of the commonly prescribed prescription drugs, and help people understand as they're shopping around for their Medicare Part D plan that they should look at the formularies and make sure that their drugs are covered on the formularies and use that information as they're making a choice, as they have each year to decide which Part D plan to sign up for. We also have put out an infographic and a script that people could use for their call centers so that if there's specific questions around the M3P plan, that it is a helpful guide for people who are either beneficiaries themselves or people who are helping beneficiaries make these decisions.
Wonderful. And I do want to come back to the formulary and how to read the formulary issue in a minute. But Kim, I know NHC has done a lot of education at the beginning of this year on the M3P, I think through the Trusted Messenger campaign. And I'm sure seeing some of the data that Bonnie just referenced, I'm sure you're planning more education and outreach in the coming months. I was wondering if you can maybe briefly tell people a little bit about who NHC is, and then kind of what have you done on the MP3, M3P, and what are you planning to raise awareness and make sure that anybody who could benefit from the program is aware?
Thank you. Thank you so much, Karen. It's so nice to see everyone. Many of our wonderful members are also on this call, and it's great to see Bonnie and Tiffany as well. So just as a reminder, in case there may be some folks on the phone who don't know me, I'm Kim Beer. I'm the Senior VP of Policy and External Affairs at the National Health Council. I joined the National Health Council in March, so probably at the tail end of this campaign, though my colleagues have educated me, and of course, I have been quickly educated on the importance of not only the program, but education. So I want to highlight and applaud Bonnie and the work of MapRx too, because there can't be enough education about this program for seniors, especially as they try to manage not only choosing their own health plans, but also navigating the programs within them. For those who may not know, the National Health Council is a nonprofit membership association. And primarily nonprofit advocacy organizations are at our core. However, Bio is a wonderful member, many industry partners. We have those impacted and represent health-related advocacy priorities. So we all work together. We have over 100 members. We represent and elevate the patient voice. So we really try to keep the patient centered at all health policy decisions, and we try to lead advocacy campaigns and education campaigns that impact the healthcare system and the ecosystem holistically. So we are very grateful for our members and all of our partners on the call. And one of our campaigns that we have coordinated and designed are around this Trusted Messenger campaign that Karen referenced. And as I mentioned prior to my joining, the NHC executed an education trusted messenger campaign that focuses on empowering patient and caregiver voices to raise awareness about these key policy changes. So it was a massive coordinated effort through our communications department and our policy department to educate people with easy to share videos, infographics, and toolkits to explain how this program works, especially as they manage their out-of-pocket costs and understanding that they have options to manage their out-of-pocket spending. So through these public education efforts, we reached millions of patients. I'm happy to share some of those impact data. I'll make sure I share it with Karen. At the moment, I can't pull it up in the chat, but I'll make sure that you have it. We want to ensure that it was plain language content, community-based outreach, and I know we probably worked very closely with MapRx and other members who are very interested in ensuring that this information got out. We learned that there's a lot of effectiveness. As we all know, we live and breathe on social media, and so using visual storytelling, leveraging community voices and highlighting those impacted, offering materials in multiple formats to reach more diverse audiences. This is part of a greater part of our mission and initiative to equip patients with knowledge to navigate the health system that continues to become sometimes a little more complicated. However, there are many wonderful programs that patients really need to hopefully elect to take part in, so it makes their lives a little easier and more affordable. We'll continue to educate and work with our partners, especially around open enrollment. And we're also gearing up. I know we'll get to this a little later around the Medicare drug negotiation program, but we're thrilled to be working with our partners to continue awareness around M3P.
I think you already alluded to this, but in the incredible campaign that you and at the end of last year and the beginning of this year, what were some of the learnings? What messages resonated most? What messengers, what channels, and like how are you thinking about reaching in particular those seniors who maybe would benefit but aren't quite aware of the M3P program yet?
Well, as I mentioned, I think visual stories highlighting community videos and leveraging communication channels through, radio and social media, and really targeted campaign to certain segments of the population, I think were effective. I think as Bonnie talked about some of the challenges of sort of uptick and continued education, I think that there's room, for improvement there. This was a new program with lots of changes and a change in administration also. So I think this is just my feeling. I don't know if others agree with me that maybe some of that was lost with some of the initial changes with the new administration. I would imagine that maybe some of the messaging, um, was diluted at times. I don't know. I'd love to hear from my other colleagues on the panel.
Bonnie, thank you so much for sharing the Open Enrollment Guide. Any thought from you to what Kim just mentioned?
Yeah, I mean, I would just underscore what Kim said, and I think, anytime there's a transition, some things get lost in translation, and I also think that these programs, the M3P and the other policies are part of a very large bill that made very substantial changes across Medicare Part D, and were not supported in large part by the party that controls the administration in both houses of Congress right now. And so I also think that that puts another layer where you would expect any new administration, especially if their party did not support the law as it passed, just review and sort of see what tweaks they may want to make, what they don't agree with, what they'd like to change. But I will say at the same time that when this law passed, there was a very tall order by Congress to the administration to get everything implemented very quickly during the Biden administration, and that was done. And I think anytime you have these very tight turnaround times for new programs, new policies, for example, creating a whole new part of CMS that is negotiating drugs, it has been a lot of work by CMS in a short period of time. And this year is no different in that way, too. There's been a lot of ongoing issues, which is why, Karen, I'm so glad that you invited us all here today, because I think it does take a joint effort by all of us to learn and to compare notes, and then also join our voices through each of our organizations, so that we can be heard by Congress and by the administration.
That's
And
very
Karen, oh, may I just add one thing, Karen, because I think I was a little clumsy in trying to describe it. You asked us like what was most effective, and it sounds silly maybe even, but a trusted community channel that I consider the National Health Council that vehicle, along with many of our other partners on the phone. And because our work is focused on the patient advocacy organization and elevating the patient voice, coupled with the fact that the information was visual and plain language with telling a story, I think really was able to reach many segments who hopefully we wanted them to receive the message, and builds understanding and capitalizes and emphasizes the trust they have with organizations like ours. So we hope to continue that, and obviously there's lessons learned there, but I also appreciate Bonnie's additional expanding on some of the challenges with the transition and some of the technicalities that occurred through how complicated the bill was.
And Tiffany, I see a lot of head nodding. I know through your coalitions, the Each and Pick coalitions, you hear directly from the impacted patients on, I would say, a daily basis. I was wondering if you can briefly talk about what those two coalitions are, and maybe one of the things that I think is underlying the whole M3P idea is, what does affordability look like? And I know you all have collected a lot of data on that as part of your work your broader work. I was just curious if, based on that, you have any thoughts. I know we've had that conversation about how affordability can mean a lot of different things based on the context. So, if you wouldn't mind.
Sure. So, hi everybody. Tiffany Westridge Robertson. I am first affiliated with AI Arthritis, which is International Foundation Autoimmune Autoinflammatory Arthritis. I always say we had AI well before AI had AI. And in saying that, we are driven by patient voices. Myself, I live with axial spondyloarthritis, and by design, all of our public-facing staff also live with our diseases. And a shout out to Mark Hobrach. I saw him on here, person living with ankylosing spondylitis, our director of of public policy. And then in 2023, at the onset of CMS IRA, and then also the first of the prescription drug affordability board reviews that started in Colorado, it was sort of the shift of a new era of patient engagement where, especially in the PDABs, the patient organizations were sort of being pushed out in Colorado in particular. They wanted patients, they wanted real patients, which I am, but what they were looking for are patients that are not necessarily affiliated as advocates or educated in any way on the policy system. In saying that, AI Arthritis always has had this model where we try to put everything in layperson terms, where it's really about patient experience data driving reform and driving changes. It's been our model since inception. And so at that time, everyone sort of looked at us and said, maybe it's time you all run a coalition. So we established the Ensuring Access Through Collaborative Health and Coordinating Patient Inclusion Council in early 2024 in a response to these government drug affordability reviews covering both CMS, IRA, and also the PDABs. In saying that, it's a unique model in that each side are patient organization and allied group representatives. We say participants as we don't have official membership because the topic is so toe in, toe out. And so we just got to say, we have over 80 on our participation list. So I will definitely share the link with you. If you're not already part of this coalition, definitely encourage you to do so that we can keep you informed and opportunities for you and for patients to get involved. We also established the Patient Inclusion Council. So this is very novel, to our knowledge, the first of its kind, where it's a patient and caregiver coalition that operates both independently and in unison with each side. So patient organizations who have patient advocates, we encourage them to connect them to the PIC. So it really helps with administrative burden as well, because our organization and always each side invited to participate in the PIC. So there's always this ground, always this education, always this opportunity for patients to stay engaged, to stay involved, to ask questions. And when it's time to initiate speaking, CMS, IRA, or otherwise, we already have a pool of patients. So that is the way that it was ideated. And it's taken a while to build out, but we definitely have been doing a lot as far as impact goes. In saying that, I do want to just, I'll circle back to what you said about affordability and the data, but I do want to just also mention, just because I've heard so many people say if there was only a repository of how to follow IRA, how to follow the PDABs when it comes to these government drug affordability reviews. We do have a full built out Slack community with a channel for every single one of them. So it's the best place to just go in, see what you need, go out, and you'll be updated in 10 minutes. So if you're not part of the coalition, again, I definitely encourage you to do so. In saying that, one of the big things that we took on, in addition to the coalition work on this, is realizing nobody's asking what, the big question, affordability for who, and what is affordability anyway? So when you think of data, you always need endpoints that you're measuring towards. Otherwise, it's very much a tick of the box. And while CMS and the negotiations are slightly different than the PDABs, they do have one and the same, in that there's not unified definitions of what affordability is. And if we're going to be really focusing on what patients say is affordable, first of all, we need to know what they think it is. We need to know what each perspective thinks that affordability is. Because then what is the outcome? And one of the things that we realized through our data is patients are largely reporting if their medication is affordable or unaffordable, based largely on access, and something that was brought up earlier, the multiple medications. That's just such a big contributor to this. We love the fact that the spread pricing is coming out, because when patients are reporting that their drug is unaffordable, they're really saying, is it something that I can pay the rest of my bills? Is it something that I can still, and my family can live and function without having to sacrifice too many things? We've had about 400 patients submit on what their definition is affordability, and that's really what's coming through. And how do I balance chronic condition? How do I balance a family where we've got X amount of people on X amount of prescriptions? Because when we asked the question on out-of-pocket costs, those who paid $0 to $10, 20% said that was unaffordable. And what we found was, because of this kind of multiple medications, 10 times 15, now it's unaffordable, right? And so there's a little bit of a misnomer when we're addressing affordability. We need to get down to the data and what's really affordable, what it means for patients, and if we can solve it. The other thing that rooted from that is if they had access to financial assistance, which we know is a very big issue when it comes to Medicare versus commercial insurance. And so that's something that we also need to zero into as we're talking about affordability. But I could go on and on. So I'm going to let you, Karen, direct me to what specifically you want me to talk about next, or if you would like to turn it back over to Kim or to Bonnie.
I would love to see if Kim or Bonnie, if you have any reactions to that. Otherwise, I have a million questions, but it does strike me that the ability to spread out costs so you're not hit with that whole out-of-pocket cost of up to $2,000 in January, that can really impact, really resonates with that concept of that you just mentioned, of multiple medications, etc. I know communicating about this with patients and helping patients decide whether M3P is the right thing for them, Bonnie, as you said, can be a case-by-case basis.
Yeah, Tiffany, I really appreciate all that you said, and also wanted just to mention that in early conversations with CMS, one of the things during the last administration and working on implementation of the MP3, one of the things that they seem to be very concerned about is that their words, the wrong beneficiaries would join M3P. In other words, they were concerned that LIS beneficiaries who qualify for LIS extra help on their premiums and deductibles would sign up, and it's very much not appropriate for if somebody qualifies for LIS, that's the program they should be in. And so we think that they may have set their target population with the out-of-pocket costs too high. And I think what Tiffany said sort of underscores the point, just of how much trouble people can have managing these costs, and that, while ultimately the M3P doesn't make anyone's costs go down, it does make costs more manageable. And we really believe it will help adherence. One of the things that we have asked CMS for and will continue, and I know others on this call have asked as well, for CMS to share data, make public data about enrollment in this program. They have not released anything yet. And we think that is also just another good starting point for us as we're learning about how to answer the very good questions, Karen, that you're asking. Who are the best messengers? What's the best path for information? And we can use our sense of logic to look at now what beneficiaries have to do, and know that it's not easy enough right now for beneficiaries to sign up for this plan.
Anything from you to add, Kim? Otherwise, I would love to transition. We could keep talking about this for an hour, but just looking at the time, I want to go back to, and Tiffany, you already alluded to it, the CMS listening sessions, giving patients a voice when it comes to the drug price negotiations under the Inflation Reduction Act. And Tiffany and Kim, I know both of your organizations have a very long history of working closely with CMS to really make sure that the patient voice is heard. I would love to hear from both of you what have been some of your learnings from this year's round. And now that the IP28 guidance was just finalized, how are you looking ahead to next year? How do you prepare? How do you make sure that patients are equipped and have the information that they need so that their voice can really be heard? And I don't know who wants to go first.
I'll go ahead and jump in real quick. Yeah, I also as a patient who had experience with drugs on both of the lists, I also participated as a patient as well. So, and participated as patient organization. And I can say what I would give kudos to CMS for is they are doing a good job of trying to listen and incorporate what they are able to. There was quite a bit difference in the listening sessions from the first year to the second year, and that the second year they allowed them to be private. There's always still things to work around. There was a cap at 9 people. There was, it was difficult sometimes to get a word in. So there was a high looking at the chat. So knowing that ahead of time and being able to have answers that you could copy and paste in there. So it's just some lessons learned about that, and letting patients know, even if you were not picked, because that happened. We had recruited, I think 11 people, and like 3 of them did not actually have the opportunity because the 9 were already filled in each of them. So letting patients know they actually still had the opportunity to submit comments after the fact, and for a few weeks actually. So just those types of things are good lessons to learn. But in preparation, we really have to start with the education on why this is important. We need to do it now. I did write some notes down about what Bonnie was talking about and Kim were talking about on just if we look at CMS in a whole, there's a lot of points, there's a lot of education, but all of these points could be harnessed together in some type of learning experience for patients, and they almost could pick, mix and match on what is of interest instead of bombarding them all separately. Because, so I do think that there's a lot of in knowing how to elevate a voice, plain language, some of the things with cost and affordability, finding a way to package these together as a group, but making sure that patients now are able to start being educated. So maybe it's now with enrollment, then as we move into the negotiation, are you on these drugs? Do you have, so now we already have them, right? And so I think that's very vitally important. And when we say, I like the word prepare, one of the things that we will never do at the coalition is script. And so, especially when it comes to negotiations, helping them craft their truth and their lived experience is vital. And the last part, and we'll still be pushing CMS with this, is really understanding what's happening with the data and how patient involvement is even driving any of the decisions that's being made. It's pretty radio silent when it comes to that, which really does feel like a tick of the box. And if patients continue to give their precious time and they don't see how their precious time is actually of true value, they're going to stop participating. So I just find, I think that's really, as we come into now the 3rd year, we're going to have to push for them to disclose how the patient voice is actually being implemented.
And Kim, I know your organization for 2 years now has really done a great recap and deep dive, talking to a lot of patients and patient groups that have been engaged in these listening sessions and collecting feedback and information. Can you talk a little bit about kind of your learnings from the first 2 years and how you're looking ahead to next year?
Sure. And I also want to just emphasize everything that Tiffany said. I think so. Yes, the NHC has been actively participating in the last two cycles to ensure, as best as we can, to ensure that the patient perspective to inform this process is included. And sometimes we have to do this in a short time frame. These sessions, this can't be overstated, are a vital channel for patients and caregivers to share their real world insights and understanding that this is probably a very new process for CMS. And also, it's not set in statute. So I think that's also important to acknowledge. So we're grateful that CMS is continuing to obviously have this process because it's really important that we continue patient engagement and that they meet with us to hear our feedback and hopefully adopt changes as they move forward. So I also want to back up what Tiffany was saying too. I would say a lot of the feedback we received is around the actual process and ensuring that people have the right information, that they feel prepared, that they understand with whom they're speaking. Um, and so the transparency around that, like who am I talking to and what will happen to the information that I'm sharing and how will it be used? I think Tiffany was saying that we heard that from our patient advocacy organizations who worked with many of their patient advocates to be a part of this process. And I don't think that could be understated, the need for that kind of transparency and understanding what is being used with the data. So we'll continue to push for that standardized patient engagement practices and the actual experience of it. So I think CMS is very open to hearing our feedback there and has made small changes over the last 2 years. So we're hoping, this process continues to improve. Being ready for this advance notice of the session so that NHC is really excited to try to do exactly what Tiffany said, is to start educating early. So we'll be we're preparing a toolkit and having a webinar to educate our members around what the process is, what have we learned in the last 2 years, and how best can you prepare and get ready for when this process starts. And then we'll continue that coaching, education throughout the entire process. So we're really excited for that. And I think that kind of information comes with time so that we're now ready to maybe start a little earlier. And I think that will be important. And yeah, and again, how is the patient voice being used and how is it being incorporated?
And I know, coming from the patient community myself, having 30 days as a turnaround can be really tight, in particular for patient groups. So absolutely, I think getting ready ahead of time as much as possible is just so crucial to minimize the um, time crunch, in particular for patients who live busy lives. They have to fit this in. Um,
And it can be intimidating. Tiffany, those of us who have worked and lived in advocacy feel very comfortable if we're sharing our personal stories. But not only is it educating patients about the process and why it's important, but then also preparing them to actually share and answer questions. So it can be intimidating and people's lives with complicated conditions that require caregivers or special times of the day, all those things have to be taken into consideration too.
Again, I see a lot of head nodding. I want to make sure that we have just a few minutes. If any other comments around the listening sessions and the patient engagement there. I know, Tiffany, you're also doing a lot of work on the PDAP side, and I know there's a lot of similarities there. Anything else to cover on that issue?
If I could, I just wanted to add, I think generally speaking, that it's our responsibilities as the National Health Council, and I'm sure my colleagues agree with me, that we continue to preserve any opportunity we can have that patients and organizations can engage with this with the agencies and with this administration. So we'll take every single opportunity very, very seriously and work as our way to communicate directly with the agency as well. So it feels even more urgent and important than ever to preserve these processes and improve them.
And I know one other area of Bonnie, did you want to
Oh,
add
I
something?
was just going to underscore what Kim said, and certainly at MapRx, are hand in hand with the National Health Council on that goal, and really believe that patients and Medicare beneficiaries really need to have a voice in the CMS policymaking process and their implementation of these important programs. And we really MapRx members have really benefited from a lot of the work that National Health Council has done, specifically on the listening sessions. And we also are working hard to make sure that people at CMS see what our member organizations are doing, hear our questions and our concerns. And also, one of the things that MapRx has done over the years is compiling our experiences, our understanding and analysis of the data as it relates to these particular programs, and presenting that both to Congress and to CMS as a way to continue our advocacy and lift up the voices of beneficiaries.
And I know you had mentioned at the beginning some of the formulary restrictions that we've been seeing, and I know that's one of the areas that both NHC and MapRx, I think, have worked with CMS on to ensure that there is appropriate oversight. With open enrollment, I was wondering, Bonnie, Kim, if either of you can talk a little bit about some of the formulary restrictions we've seen as a result of the Inflation Reduction Act, what that means, and maybe some of the work that you are doing with patient groups to help them understand formularies and make the right choices.
So I'll start and then let, I'm sure Tiffany and Kim have things to add here. But one of the things that we have seen over time, even before the passage of the Inflation Reduction Act, is a restriction or narrowing of formularies in Medicare Part D plans. It's been very concerning, and year over year, we've just seen more narrowing. Every October, CMS puts out something called the landscape files, which have been released now, and I know a lot of the number crunchers are starting to look at those to see and have some specific data. But we certainly are using those data points in our advocacy around the narrowing of formularies, but also the hurdles that Part D plans put into place through prior authorization and other utilization management tools that beneficiaries have to go through, jump over these hurdles to get access to a drug that they need, their physician or healthcare provider has prescribed for them. And so it's one of the things that we will keep pushing on, and we keep pushing as we talk to members of Congress and people in the administration to understand that really the success of Medicare Part D has been that balance of a private sector approach of having these plans offer insurance for prescription drugs, but also all of the consumer protections and oversight by CMS, and that balance that is created. And we really need to have a strong patient voice to make sure that that balance does not get out of whack. And as we watch what's happening with prior authorization, utilization management tools, and formularies, we are concerned. Looping it back to how we started, it is so important for Medicare beneficiaries to shop each year for a plan, and the formularies change, maybe the prescription drugs that they take change, and we know from data and we probably know a lot from our own personal experience. Once we have a plan, sometimes we get a little complacent and we don't shop each year, but that's if we had number one message that we're trying to get out to beneficiaries, which is make sure you shop around for your plan and do your homework to make sure you're in the best plan for your needs.
Thank you. And I see a lot of head nodding Kim, it looks like you might want to add something.
Well, but I totally agree with everything Bonnie said, and I just think it's a little bit ironic that we're sitting here within like the 16th day of a shutdown, and we're so concerned about government funding, but also open enrollment and what that the some of the tax credits not being extended, just the impact on Americans making choices about their healthcare plans across the board and so much uncertainty, and then the regular education that has to be done and the regular advocacy that has to be done. It feels, again, the sense of urgency and a little bit of confusion and nervousness around what it'll be like for many of our advocates and patients who are choosing plans. So I was just listening to Bonnie and then also thinking about like the time that we're currently in at the moment.
Tiffany, I'm sure, again, through your work, you're seeing some of these formulary changes, the impact of utilization management. I think I saw you really nodding your head a lot. Any thoughts from your perspective?
I just want to, in the interest of time, I just wanted to add, add really quick here, agree with what both have said, and just want to echo the sentiment of this ever evolving situation and narrative that patients are constantly in, whether it is new open enrollment happening right now, whether it's your formulary shifting, all of these things are very real and they're ever evolving. I can't say that enough. I mean, patients are always trying to figure out, where am I going to be able to have the best access for the treatment that I need that works the best for me, not what necessarily the insurance company, CMS, et cetera, says that is going to work for me. And so I am going to put a link in the chat. We have one of the things I think our coalition is becoming very well known for is our patient experience data collection. We posted the pilot results of the first one based on the fact that the surveys used in the IRA, also in PDABs, we're just not really getting to the why a patient's saying is affordable or their medications accessible. And all of that's going to matter on how we address the solutions. And so in saying that, this one closes on October 31st, but to Kim's point, it'll be very interesting to see the answers now versus when we relaunch another data collection effort after open enrollment, after we see what happens with the changes that move forward. So that kind of data collection is also just so important to complete or to be in addition to what's happening with the other data. This is very patient raw data, patient truths that are hopefully not going to become a supplement, but will actually, the goal is to drive reform with them. So you can kind of see how the three of us being part of these bigger groups, these bigger coalitions, also part of each other's work, also really the importance of everybody kind of has a role, but we all also operate together, and together is stronger. So I just can't thank enough for Kim and for Bonnie too for the work that they're doing at their groups.
I love that. And if I can just ask each of you, for some of the maybe younger groups in the audience that are seeing all these that are trying to plug in and do the education for their constituents, for their patient communities. What advice do you have in addition to joining your groups, obviously? But yeah, would love everybody's advice. I don't know who wants to go first. Bonnie,
I'll go first, and that's a great question, Karen. I feel for all of us, but especially for people who are relatively new to this space. It is such a frenetic space right now with implementation of a huge law that passed a few years ago, making major changes to these programs, and then a new administration where really weekly we're hearing announcements about policy changes that really could impact the people who your organizations are working closely with. And so I just want to circle back to what Tiffany said, which was, you really, at this point, really need to look to trusted sources of information because it's all too much for any one person to read the regulation, to be talking to people in the administration in the Hill and know what's coming down the pike and understanding the perspectives of different stakeholders. And so, speaking for MapRx, one of the things that we really try to do is be a trusted source of information on Medicare Part D and really be an early warning sign. If there's an issue that is coming down the pike that we think is going to impact beneficiaries, we will let you know. We'll provide information. We will provide advocacy tools and other collateral that you can use to educate your own organization and or engage in advocacy with the administration or with Congress. And MapRx, specifically, our model is to, if you are a national organization that represents Medicare beneficiaries, we would love to have you at our table. We do not charge for membership. So I did put my name, my email in the chat. And so please reach out if you're not already a member. And, I do see a lot of our members around the table. So I can also give you a reference if you want to talk to Roxanne or Mark or others about MapRx and get their viewpoint too of how it's been a helpful tool. Thank you, Karen.
Fantastic.
I'm happy to go quickly back up everything Bonnie said. Trusted resources. We all work together, so that I think that's important sometimes for people to hear, especially for organizations who may be members of different different organizations that overlap. We do work together, and if you're not members of our organization or MapRx, our website has all of our letters and comments posted. We have our trusted messenger campaigns on our website. Feel free, obviously, to look at those and read those. The team I get to work with is extraordinary. So Sean Chang, Jen Dexter, Alan Pinn, we're all here to help support, explain anything to anyone who's interested in learning more.
Fantastic. And Tiffany, last but definitely not least, last word to you.
Just seconding what they're saying. And lastly, I think we all work together and separately. We all have certain toolkits, certain value, certain things that we can bring to the table. So definitely check out all of them. And as long as you're connected with all three, I think you're gonna find exactly what you need.
Fantastic. Well, I certainly learned so much today. Thank you so much for sharing your insights, your expertise. Thank you for what you do every day to help the patient community. And thank you all for joining us today. And I'm hoping to see many of you next week at our in-person summit in Washington, D.C. Have a wonderful rest of your day.
Thank you, Karen.
Thank
Bye-bye.
you. Bye. Thanks, everyone.
Thank you.